So thank you all, like I said, thank you all for coming. So this is the first part in our new Obs and Gynae Crash Course series, and we're joined by the lovely Priyanka, who has kindly offered to do all 4 parts of it. So it's going to be a really well-structured, really informative talk, so we hope you enjoy it. Just some quick things to say before we start. Please keep your microphones off, cameras off, so we can all focus on what's going on. There will be a feedback form at the end. So once you fill that out, put in your email, we can email you over a copy of the slides. That will be right at the end of the presentation. And the rest of the series, so for the next 3 weeks, it will be the same time, Sunday at 7:30. So please make sure you're joining us for that. So I'll now pass on to Dr. Priyanka.
Okay, can you guys hear me okay?
Yep.
Okay, amazing. So hi everyone, I'm Priyanka. I'm a Foundation Year 1 doctor at Newham, which is in Northeast London, and I graduated from King's not so long ago. I'll try to cover as much as I can of Obs and Gynae in these 4 sessions. And today's one is Obstetrics 1, and these are some of the topics that we'll be covering. So bleeding in pregnancy, and I've split it up into 3. So less than 24 weeks, over 24 weeks, and then postpartum hemorrhage. Common presentations in pregnancy, specifically looking at nausea and vomiting and itching and rash. Then routine antenatal care. So what are the blood tests that you do during pregnancy? When do you do them? What are some of the scans that pregnant women get? And then how do we screen for your chromosomal abnormalities? What blood tests, what ultrasound scans do we do? So the key is routine antenatal care. So this is what all women get, whereas obviously some women might get some extra scans and some extra blood tests. And then we look at rhesus incompatibility disease, because that's something that I sort of as a concept really struggled with. And that's something that might come up in like OSCEs and like questions and stuff. So hopefully we'll try and do that at the very end. I've also included what we'll be covering in the other sessions as well. So hopefully when you guys get these slides, you'll be able to see what's coming up next. And if you want to, you can read up about the stuff before the sessions. So yeah, that's some of the other topics. So yeah, yet another Mentimeter quiz. So if you guys can scan the QR code, or you can go to menti.com and use that code. So we'll be using it for a lot of the like interactive bits of this, this session. Okay, cool. So yeah, so hope I'll give you guys a little bit longer just to get on to that. And let me put the code in the chat as well, just it takes people a bit longer. So it's menti.com and the code is 871-8731382. Okay. Fine. So here's your first question. So you've got a woman that comes in, she's less than 24 weeks pregnant. She's come in with some vaginal bleeding. What would be some of your differentials? So if you guys can just, on Menti, if you can put in some of your differentials, that would be great. Okay, so we've got 16 answers so far. I'll wait until it gets to around 50 and then I'll show the answers. Okay, so that's 50 now. Let me show the results. Great, okay. So the most common ones that are on here are ectopic pregnancy, miscarriage, perfect. We've got implantation bleeding as well. That's another one. We've got some other things like placenta. Let me go back. Sorry, give me 1 second. Let me just go back to that. Let me just play it. Okay, yeah. So we've got miscarriage, ectopic pregnancy, implantation, bleed. We've got some other things like placenta, Praevia, and placental abruption as well, which we'll come on to in the next question. But yeah, so the most common causes of bleeding under 24 weeks are actually ectopic pregnancy and miscarriage. And you've got some other less common causes as well. And we'll go through some of these. So the first two are the most common ones. You can also get bleeding under 24 weeks with molar pregnancy as well. And some of the other ways that this can present is if the woman is large for dates, and she can also present with severe morning sickness. And we'll go through exactly why this might happen. And the last one is you can always have gynecological problems that can give you bleeding in pregnancy. So things like infection, having a polyp, having a cervical ectropion. So does anyone know what this sign is on an ultrasound scan? Let me try and get the chat one up. Yeah, so it's snowstorm appearance, exactly. And that's what you'd get with a molar pregnancy. So it's sort of like all the different, so with the molar pregnancy, you sort of have this proliferation of the placental tissue, and it sort of forms this like lots of different, I think it's called like a bunch of grapes appearance as well. So yeah, that's something that you would see on an ultrasound scan with a molar pregnancy. Perfect. And what do you guys know about cervical ectropion? What sort of things can put you at increased risk of getting an ectropion? OCP, yes, exactly. And anything else that would increase the chances of having an ectropion, which we're actually talking about right now? Yeah, pregnancy, exactly. So an ectropion classically presents as post-coital bleeding or bleeding after sex. And it's sort of like a hormonal cause for it. And essentially what you have is you've got your columnar cells. The way I remember it is the cervix is, it's like a column. On the inside of the cervix is like a column. So the inside has columnar cells and the outside has squamous cells. And what happens with an ectropion is the columnar cells sort of get exposed, and you can see it as like reddening when you do a speculum exam. And yeah, so it can present as bleeding after sex. And the way that do we know how we classically treat an ectropion? That's very problematic. Often you don't have to do anything about it, but if the woman's troubled by it, then you can do something. Silver nitrate. So there's something else that they usually do with ectropions. Not quite curettage. Cryo, yeah. So cryocautery, I'm guessing you mean like cryotherapy, yes. So essentially what they do is the first thing you have to do is you have to rule out cervical cancer. So you need to make sure that they've had normal smears, because cervical cancer can be another cause of postcoital bleeding. So you want to rule that out. Once you've ruled that out and you're happy there's nothing malignant going on, then you can use cryocautery. And essentially it's just like, it's really cool. You just sort of like apply that and it should hopefully treat the cervical ectropion and you shouldn't have any more symptoms. But yeah, always think of other gynae causes as well. But remember, the thing that you need to rule out in someone who's bleeding very, very early on in their pregnancy. So ectopic pregnancy, the bleeding is usually quite early on. So you have to rule out an ectopic. And like, I think you guys it's probably been drilled into you as well, because it was drilled into me during med school, is like anyone who presents with abdominal pain to the emergency department, you need to do a pregnancy test. And just something to keep in mind. Okay. So ectopic pregnancy. So it's basically where an embryo implants outside of the uterine cavity, and the ampulla is actually the most common site where you have implantation. So the tubal ectopics are the most common, and within tubal ectopics in the ampulla is where you most commonly get an ectopic pregnancy. So some of the risk factors are if you've had an ectopic in the past, and this is sort of like a rule of thumb for most things in pregnancy. If you've had it in your previous pregnancy, you're going to have it again. That's the same with GDM, with preeclampsia, with ectopics, with like most things, that's sort of like your go-to. And then the biggest risk factor, I guess, for an ectopic pregnancy is damage to your tubes. So pelvic inflammatory disease, STIs, any previous surgery on your tubes as well. All of those things would increase your risk of having an ectopic. And then assisted conception as well also increases your risk. I've put IUS and the copper IUD in blue only because they don't by themselves increase their risk. But if someone has a Mirena or a copper coil in situ and they do get pregnant, then you want to think then the chances of it being an ectopic are much more likely, because they protect against, like uterine pregnancies. But if you do get pregnant whilst you have this in place, then you're more likely to get an ectopic pregnancy. But by themselves, they don't increase the risk. Yeah, as I said already, always do a pregnancy test in a woman of childbearing age presenting to the ED. And this diagram just shows you the tubal ectopics are the most common, but you can get things like a cesarean section scar ectopic, which I've seen at Newham, which is sort of like where the ectopic essentially implants into where you have the cesarean section scar. And it's quite a risky procedure because you have to make sure that you don't perforate the uterus whilst you're doing the DNC essentially for this one. You can also get abdominal ectopics as well. You can get intramural, cervical, but the most common ones are tubal ectopics. And that's basically what you would see on laparoscopy, and that's an ectopic over there. Okay, so presentation and initial management. Do we know how do we think a ruptured ectopic would present? So what are some of the things that you might pick up on examination or from the history? Sorry, I'm trying to get rid of this thing. Okay, you see the chat. Shock, shoulder tip pain, perfect. Anything else? Hemodynamic instability, yes. Yeah, pain. RIF pain, good. PV bleeding, colicky pain. Good. So the main things are with a ruptured ectopic, if you think about it, there's a lot of blood. You have hemoperitoneum, and that's going to irritate the diaphragm, and that's what gives you the shoulder tip pain. You can also get a peritonitic like abdomen as well. So you're going to get rebound tenderness, you're going to get guarding. And if you guys have done your ED placement, like literally ED doctors love doing fast scans. Like anyone with any sort of, pathology, they're like, oh, let's do a fast scan. So that's basically looking for blood in the, in the peritoneum. So you look at the liver, you look at the spleen, particularly in the hepatorenal pouch or the pouch, you can look in the pouch of Douglas. You basically just look for free fluid in the abdomen. And essentially with cases of a ruptured ectopic, if you do like an ultrasound scan or a fast scan in ED, then that's going to show you blood in the abdomen. And that's a very quick scan that you can do. And it's, it's quite sensitive for that. So like you guys said, you get lower abdominal pain, and this sort of progresses into scanty dark bleeding. But the important thing to note is sometimes you don't even get the bleeding, all you get is the pain. So it's important to have a high index of suspicion in anyone presenting in this way. The pain is initially colicky because sort of like, if you think about it, the tube is sort of like trying to get rid of the pregnancy, but then it becomes constant. And symptoms of a ruptured ectopic, you guys have said, shoulder tip pain, syncopal episodes. But like I've said, only under 25% of women actually present this way. And on examination, you guys have said already, you might have hemodynamic instability. So tachycardic, hypotensive. Hypotensive is actually less commonly seen because these women are quite young. They're going to compensate very well. So all you might see is tachycardia, but that should be enough of a suspicion for you to think, okay, she's compensating for something. What's going on? Abdomen, you might have rebound tenderness, especially if it's ruptured ectopic and you've got blood in the peritoneum. And on vaginal exam, you might have pain on cervical excitation, and you might have tender adnexae as well. And the way that you test for cervical excitation is you do a bimanual exam. You're pressing on the uterus from above, and essentially you just try to get underneath the cervix and just try to like push it up and down, essentially. And and if that causes pain, that's pain on cervical excitation. And then you also check for, on a PV exam, you would check for the adnexae. So you check that that's tender as well. And that's another thing that would increase your suspicion of having an ectopic. And your cervix would be closed on vaginal exam. So initial management for any, acute presentation, it's A to E. You want to get good IV access. So ideally 2 cannulas, you want to take bloods for, all your routine bloods, but the 2 important things that you want to take in anyone that's bleeding. So group and safe, and in case of this, if it's an ectopic pregnancy, you want to do a beta HCG as well. So you do a urine pregnancy test, but you also send off a serum beta HCG. And you do an ultrasound scan. So like I mentioned, you do sort of like a fast scan in ED, but you also want to do a transvaginal scan as well, because that's what would tell you if it's an intrauterine pregnancy, is it an ectopic pregnancy. It would give you the size. It would show you things like if there's a fetal heartbeat present, all of those really important things you'd get from a transvaginal scan. But an ultrasound scan is really good in ED, especially if a woman's unstable, you want to decide if it's ruptured or not. Because if it's ruptured, then you don't need to do a transvaginal scan. You can just take her straight to theater, especially if she's unstable. So this is what I was trying to show you. So this is free fluid in the Morrison's pouch, which is sort of like between your liver and your kidney. And if you've got any blood in the peritoneum, it sort of collects over here. And this is something that you would see on a fast scan. So with an ectopic pregnancy, you've basically got 3 management options. You've got expectant, which is where you wait and watch. And this basically means that you'd monitor the lady over 48 hours and you'd recheck her beta HCG. You've got medical, which is a single dose of methotrexate, but you need to be able to follow up the patient. So if the patient's not able to come back, then that's probably not the management that you'd go for. And the last one is surgical. So a lap salpingotomy, which is basically where you just remove the ectopic pregnancy, or you can do a salpingectomy, which is where you remove the entire tube. The really important thing to do when you're doing a laparoscopic surgery for this case is to actually check what the other tube looks like, because if the other tube is damaged, if it's got like a hydrosalpinx, which is where you've got fluid in the fallopian tubes, then you'd probably think about, conserving the other tube, which has got the ectopic pregnancy, so just removing that. And so these are some of the criteria which would make you decide between expectant, medical, or surgical. So if the size is under 35 millimeters, then you can go for an expectant or medical. If it's unruptured, that makes sense, you'd go for expectant or medical. If it's ruptured, then you'd go straight for surgical. If she's symptomatic, so if she's got things like abdominal pain, if she's got shoulder tip pain, if she's parasynetic, again, straight for surgical. If there's a visible fetal heartbeat, again, you'd go for surgical as well. And another reason why you would have to do a serum beta HCG is because it would help you determine which one you'd go for. So if it's over 1,500, you'd go straight for surgical. This is a useful table that you guys can, use when you're revising and stuff, because that's another question that often comes up. Would you do expectant, medical, or surgical management? So it's good to know exactly what you would use. And another important thing to remember is if the woman's rhesus negative, then an ectopic is a sensitizing event. So if you're doing surgical management, then you need to give her anti-D. I can see there's some questions. Let me just try and get it up. Oop. Is it done lying down? So if you think about, so it is actually done lying down, the fast scan itself. So if you think about the hepatorenal pouch, it's sort of like at the back. So the blood sort of tracks from the front and it sort of lies at the back. So you'd be able to see it actually on a fast scan, even if the woman's completely lying down. It's sort of like all the fluid collects in all of these pouches. So it is quite sensitive. The pouch of Douglas is between the rectum and the uterus. Yes, that's right. Whereas a pouch of Morris is, I don't know if I got that. I got confused with that. Yes, the pouch of Douglas is between the rectum and the uterus, and the Morrison's pouch is between the liver and the kidneys. That's right, yeah. And what does the methotrexate do in an ectopic? Is it just for infection? So the methotrexate is actually, so it's a folate antagonist. So it sort of stops the cells from growing, if that makes sense. It sort of kills the fetus. And that's how it works. Oh, Envy's already answered that. So yeah, that's what it does. It's teratogenic. So it's, that's how it sort of like kills it. And how does serum beta HCG aid in choosing the treatment? So I think from what I understand, it sort of correlates with the size of the ectopic. And I think also if the serum beta HCG is very, very high, then the chances that, you'd be able to successfully manage an ectopic through expectant and medical is lower. So I think it's more to do with your success rate. So if you've got a very high beta HCG, you'd probably go straight for surgical because, you don't want the woman to keep coming back. So you want to try and get, rid of this ectopic pregnancy that's not viable. So that's why you sort of check the serum beta HCG levels. That's how I understand it. And how common is it for ectopics to resolve on their own? I don't actually have a statistic for you, but it can happen. The next question, if it's over 35 millimeters but unruptured, do you still do surgical? So according to this table and from like what I've seen on in textbooks and stuff, yes, but I don't know in clinical practice if it's as straightforward as that. I think if it's that big, the question is, I think you'd leave it to the woman as well. So you'd present her with all of her options, but you tell her that, if it's over 35 millimeters, the chances are that if you do medical, you might have to come back and end up having a surgical procedure because it might not successfully end the ectopic, terminate the ectopic pregnancy, if that makes sense. So I think you're more likely to do surgical just because it's more likely to be successful in that case. So yeah, let me see if there's any other questions. Yeah, I think that's it. Yeah, I hope that answered your guys' questions. So the next sort of differential when it comes to bleeding in early pregnancy is miscarriage. And the definition is basically spontaneous loss of pregnancy before 24 weeks. And a recurrent miscarriage is if you've had 3 or more consecutive pregnancies. And that's when you start to investigate further. Do you guys know what some of the investigations that you would do in a couple that comes in with recurrent miscarriage? Yes. So I'm guessing, wait, AP, do you mean antiphospholipid syndrome? Yeah, antiphospholipid syndrome, yes. Anything else? Genetic screening as well. Fibroids, yeah. So you'd also try and see if there is a anatomical cause for the recurrent miscarriage. Yeah, you do karyotyping of the fetus. Good. So that's the definition. And actually, majority of the miscarriages occur before 12 weeks. That's something to keep in mind. And the rate increases with maternal age. And the thing that I always used to get confused with was all the different types of miscarriage. So I've put it all in a table to try and differentiate between the different types. So we'll go through that next. And the causes of miscarriage. So it's actually a really, I've seen a lot of women that have presented to ED with miscarriages, and it's really unfortunate. But the thing to remember is it's actually really common. 1 in 3 women actually end up having a miscarriage, and people don't realize just how common it is. And the causes, it's just isolated. It's not just, but often we find that it's isolated chromosomal abnormalities, and we can't really give women an exact answer about why they've had a miscarriage. But the really important thing is to counsel the woman that it's not anything that they've done. It's not to do with stress. It's not to do with emotional trauma. It's not exercise. It's not sexual intercourse. None of these things have led to a miscarriage, because there's a lot of guilt the women come in with when they have a miscarriage. So it's really important to counsel them appropriately, especially in the emergency department, where it's a horrible place to lose a pregnancy, really. So yeah, those are some of the main. We often don't really find a cause, but it is really common, and most of them happen before 12 weeks. And types of miscarriage. So there are loads of different types of miscarriages, and the way that I remember it is you've got inevitable and incomplete. So the 2 of them which start with in are the ones where the cervical os is open, and all the other ones, the cervical os is closed. So let's go through each of the different ones. So threatened miscarriage, the os is closed. And this is basically where you've got a viable fetus. So it's threatened. So nothing has happened yet, but it might go on to miscarry. So the uterus will be expected size for dates, and 25% go on to miscarry. So 75% go on to have an absolutely normal pregnancy. Inevitable miscarriage is where things have already started and it's sort of like about to occur. So you've got heavier bleeding, the fetus might still be alive, and they're going to miscarry very soon. Incomplete is where the process has already started, and as the word says, so it's incomplete. So some parts have passed, just waiting for the remaining things to pass, the remaining products to pass. Complete miscarriage. So complete is where the os is closed, everything's already happened, and the bleeding is probably almost stopped, and all the fetal tissue is passed. A missed miscarriage is where a fetus has already died in utero, and this is diagnosed on an ultrasound scan. So they wouldn't present with bleeding with a missed miscarriage. So might be a silly question, but what would you call loss of pregnancy after 24 weeks? So yeah, you'd call it a stillbirth or an intrauterine death. You'd probably call it a stillbirth. Yeah, no, it's not a silly question, actually. And I think the reason why they keep it 24 weeks is it's just like a question of viability. I think that's why they've sort of kept that like arbitrary cutoff of 24 weeks from what I've read. But yeah, feel free to let me know if that's not right. Yeah, so these are different types of miscarriage. So just remember, inevitable and incomplete, the os is open. Everything else, the os is closed. Do you guys know of any other type of miscarriage? There's one that I haven't mentioned on here. Septic, exactly. Good. And that's, as the word suggests, you're going to come in with signs of an infection with a septic miscarriage. But the important thing is any of these can also be a septic miscarriage. It's just sort of like an added thing on top of this. So investigations and management, as you guys would expect, you do bloods. You want to do visa status as well. So you want to do their blood group. If it's unknown, you want to do serum HCG levels, an ultrasound scan as well. So an ultrasound scan can be repeated. If the woman is stable, you can repeat the ultrasound scan, especially quite early on in pregnancy, because it can be difficult to differentiate between a really early pregnancy that wouldn't be seen in an ultrasound scan, and a non-viable pregnancy. So sometimes what you do is you repeat the beta HCG levels and you repeat the ultrasound scan to see if the pregnancy is progressing in the right direction. And with regards to management, what you need to know is, when do we admit someone with a miscarriage? Because most times, we let the woman go home and we let them miscarry in their own homes. But when we do admit women is when you've got any suspicion that this could be an ectopic pregnancy. If they're symptomatic, if they've got very heavy bleeding, and if they're unstable on their bloods or on their observations, or if you've got any signs of a septic miscarriage. Resuscitation. So this is something that I did see actually when I was on my Obs and Gynae placement, is sometimes what you can have is, when miscarriage, some of the products actually are sort of like stuck in the os, and it gives you what we call cervical shock. So they actually present with profound hypotension just from like the products being present in the cervix. So what you have to do is you do a speculum and you go in with tissue forceps and you just remove the products. And that's all it takes. And the woman's blood pressure comes straight up. So that's what we call cervical shock. So that's actually an important part of resuscitation, is actually removing these products. And if they are septic, then you do your septic screen, give them their IV antibiotics. And again, the same thing for, like I said, for an ectopic as well. If they are rhesus negative, and for a miscarriage, if they're treated medically or surgically, or any bleeding after 12 weeks, you need to give them anti-D. And we'll go through at the very end why it's important that we give them anti-D if they're rhesus negative. And with regards to miscarriage options, again, very similar to ectopic, you've got your expectant, medical, and surgical. And your medical is where you give misoprostol, or you can also give Miffy as well sometimes as like an addition. Surgical management is essentially, you can either do suction curettage, which is where you put an instrument in and you basically remove the pregnancy, or you can do a manual vacuum aspiration. And those are basically your three main options. Just some extra points to keep in mind. It's important to repeat urine pregnancy test after 3 weeks. And indications for surgical management. If a woman wants to have, a surgical management of a miscarriage, then that's a valid reason to give her that option. If there's heavy bleeding, any signs of infection, you'd go for surgical management. And this is a table that I sort of like created just because I used to get confused between all the different drugs that you'd use for the different different conditions. So the way I remember it is, miscarriage has a miss, so you use misoprostol for a miscarriage. And what misoprostol does is, it's a prostaglandin, so it basically causes the uterus to contract and it expels the pregnancy tissue. For termination of pregnancy or an abortion, you basically use 2 drugs, so 2 for termination. And the 2 drugs that you use, mifepristone has an F in it, so that's the first thing that you give. And if you think about how it actually works, it's an anti-progesterone. So progesterone is pro-gestation. So that's what keeps the pregnancy going. So you want to end the pregnancy and you want to soften the cervix. That's why you give mifepristone. And the second medication that you give is misoprostol, and it's got an S in it, which is what an Obs and Gynae registrar said this to me, which is like really useful. So mifepristone is F, misoprostol, it's got an S in it. And that's a prostaglandin. So that's what you give for a miscarriage as well. That's what gives you the uterine contractions. And ectopic is just the weird one that you give methotrexate in. That's the one that I just remember as the odd one out. So yeah, so misoprostol for miscarriage, Miffy and miso for termination, and methotrexate for an ectopic. Miffy and miso. So would you do a speculum and a bimanual in a woman with suspected miscarriage? I've seen different things in A&E versus Gynae. So I think in a suspected miscarriage, it is interesting. So I think, if they are bleeding and if they give you a history of, passing products and stuff, often, you might not do a speculum. And a lot of A&E sort of clinicians aren't very comfortable doing a speculum and a bimanual. And so they sort of leave that to the Gynae team to do. And often what they do with miscarriage, give them an appointment with the emergency Gynae unit, and they let them go and do a scan over there. So yeah, so I think the thing about this, the cervix being like open and closed is probably a bit more like exam questions, I guess, than what actually happens in clinical practice. So that's a good question. It is different depending on what specialty, because Gynae is very happy to do a speculum and bimanual, whereas, the ED, you're less likely to do that. How you distinguish it in Miffy and miso. So Misoprostol, it's got pros for prostaglandin. That's how I remember it. So misoprostol is a prostaglandin. Mifepristone is the other one. So it's an antiprogesterone. And so progesterone is progestation. So that ends the pregnancy. It's antiprogesterone. How does stuck products at the cervical os cause cervical shock? I don't know exactly how it happens. I've never actually looked it up, but this is what I was told, and this is what I've seen as well. They literally they're profoundly hypotensive. There must be a way that it sort of works, but yeah, I actually have no idea, but it's a good question. Okay, so moving on to molar pregnancy. So we mentioned it quickly sort of at the very start. So that's what gives you the snowstorm appearance. And it basically includes both benign and malignant proliferation of the placental cells. And risk factors are things like extremes of maternal age, being an Asian woman, being a previous molar pregnancy. Like I said, anything that's happened before can happen again in pregnancy. And presentation. So it can give you vaginal bleeding, which is why it's one of the differentials. It's very rare, but it can give you vaginal bleeding, which may be heavy. It can give you severe vomiting. Does anyone know why a molar pregnancy would give you severe vomiting? Something to do with like a hormone that's released. HCG, exactly. And the HCG basically triggers your chemoreceptor trigger zone, and that's what gives you this severe nausea. And on examination, the uterus would be very large for dates. And that's like your classic thing that you'd see in your MCQ question. And on investigation, you might see signs, you might see very high blood pressure, so signs of very early preeclampsia. And you can get hyperthyroidism as well, because the beta HCG has TSH-like activity, so it can give you signs of clinical hyperthyroidism on the bloods. And on investigation, we've mentioned already the snowstorm appearance on ultrasound, but the diagnosis needs to be confirmed on histology. So with molar pregnancy, when you do the evacuation of the products of the pregnancy, you basically send off the pregnancy for histology. And yeah, as I mentioned, very high beta HCG. So management is ERPC, which is evacuation of retained products of pregnancy. And yeah, you send it for histology, and you basically have to do serial beta HCG levels afterwards, because if it continues to be high, then your suspicion of it being a malignancy is quite high. And if women are diagnosed with a molar pregnancy, then it's really important that they have follow-up by a specialist molar pregnancy center. So I think you've got certain centers in London and Sheffield and stuff that do this follow-up, and these women need to be referred to these centers. And so I just wanted to show you this picture because it shows you the trophoblast cells, and these are the cells that basically become the placenta. And these are the cells that proliferate in an abnormal manner with molar pregnancy. And that's why it's also called gestational trophoblastic disease. And this shows you an evacuation of retained products. So basically you've got your speculum, you basically put a dilator and you put the speculum, and you've got this device, which is a curette, and that sort of like removes the pregnancy. Okay, so the next question, let me go back to the thing. So what are some of your differentials for antepartum hemorrhage over 24 weeks? Oh, I should probably have hid the results, but it's fine. Let me just wait for a little bit. Okay, so perfect. So the most common ones are placenta previa and placental abruption. Let me see what else. Yeah, vasa previa as well is another thing that I had on my list. And that's sort of like less common, but it can give you antepartum hemorrhage. And also uterine rupture, but again, very rare and one of the less common causes. But the things that you want to rule out and that'll be at the very top of your list are previa and abruption. So we'll talk about placenta previa first. So it's basically where your placenta implants in the lower segment of the uterus. So the previa bit is basically where the placenta presents first. So that's the previa. So it comes before. And risk factors for this is having it before, high parity and age, so having had lots of pregnancies in the past and also being of a higher maternal age as well, twins, and having a previous cesarean section. And apparently that's because the uterus is scarred. So that's another risk factor for the placenta implanting in the lower segment. And how does it present? So sometimes it can just be an incidental finding on an ultrasound scan, and you might just get a low-lying placenta. But until sort of like 20 weeks or so, it's actually just a normal finding. And that low-lying placenta can move upwards as you've got, formation of the lower segment of the uterus. So it's normal sort of like until around 20 weeks. So you basically repeat it again. It can give you painless vaginal bleeding as well. And this vaginal bleeding is often intermittent. So it sort of like starts and stops, but it sort of like increases in severity as the pregnancy goes on. And because if you think about it, your placenta is sort of like in the way, it gives you an abnormal lie or a breech presentation because it sort of like affects the engagement of the fetal head or even the way that the baby is sort of facing. And what are some of the complications? Because the lower segment is less able to contract, there's a massive risk of postpartum hemorrhage with placenta previa. So that's something to keep in mind when you're considering delivery. And placenta accreta as well. Do we know what placenta accreta is? Premature separation, not quite. That's what we're coming on to. So it's abnormal attachment to the uterus. Yeah. So one of the biggest risk factors of placenta accreta is having a previous cesarean section. So it sort of weakens the uterus and you've got abnormal implantation. I've got a picture on the next slide which shows you the different types. Yeah, so it's abnormal implantation of the placenta basically. And the important thing to keep in mind is any woman who's got an antepartum hemorrhage, you should never perform a VE just in case she's got placenta previa, because that can then precipitate a massive hemorrhage. So unless placenta previa has been excluded on a scan, and by that I mean, if she's had a scan a week or 2 weeks before that, which shows that a placenta is quite high up, it's posterior, it's way away from the cervix, then you're happy to do a VE exam. By VE, I mean a vaginal examination. But if you haven't been able to exclude it, then you wouldn't do a vaginal examination just because of that risk of bleeding. How do we manage placenta previa? So you basically rescan them at 32 weeks because before that, it can be normal and you might have some upward movement of the placenta. And you basically admit women if they've got any bleeding for a period of observation, just to take their bloods to see if the bleeding settles and if you're happy to send them home. You'd also do a CTG as well to assess fetal well-being. If they're under 34 weeks and you are planning delivery, then you might consider a course of steroids. And why do we give steroids in women who are under 34 weeks? Yeah, surfactant development, exactly. Which then allows the fetal lung to mature. And then if they're absolutely fine, if they're stable, you can send them home, but you'd book them for an elective C-section at 39 weeks. So this is basically a picture that shows you the abnormal. So accreta is basically where you've got abnormal implantation. Accreta is where the placenta completely, implants all the way through all the layers of the uterus. And then percreta is basically where it can invade and it can go into the bladder and any surrounding organs. And the biggest risk factor is having a cesarean section or multiple cesarean sections, actually. So placental abruption is where you've got this premature separation. So it's all or part of the placenta separates before delivery of the fetus. And risk factors are IUGR, which is intrauterine growth restriction, preeclampsia, hypertension, maternal smoking. I think the other thing was cocaine use as well that comes up on PassMed a lot, and having an abruption in the past. And this picture is quite good because it shows you that there's two types. You've got your revealed abruption, which is where you might have a lot of blood loss, but you can also get a concealed abruption as well, where you mainly have pain and the degree of blood loss might not be in keeping with the amount of pain or how hemodynamically unstable the woman is. That's just something to keep in mind. You've got your revealed abruption and your concealed abruption. And how does it present? So you basically have constant pain plus or minus bleeding. You might get maternal collapse, you get fetal distress on CTG. On examination, classically, they say you have a woody, hard, or a tender uterus. You might, and the complications are, there's a very high risk of fetal death with placental abruption. You might also get things like renal failure, poor urine output, all of those maternal complications as well. And how do we manage it? So admit and resuscitate if it's severe abruption, and any sign of fetal distress on the CTG, deliver them ASAP. So if there's no fetal distress, if it's a preterm pregnancy, the symptoms are settling and it's quite a minor abruption, then you might consider conservative management. Okay, and this is just a table that shows you the differences between abruption and Praevia. So like I said, in abruption, the shock might be, not in keeping with the amount of blood loss that you see, whereas in placenta Praevia, it's sort of quite similar. In Praevia, pain is uncommon. You get occasional contractions, but the severe constant pain is more common with abruption. And in placenta Praevia, like I said, you sort of have a lot of intermittent bleeds, and the bleeding may be, whereas in placental abruption, you might have quite dark bleeding, or you might not have any bleeding at all if it's a concealed abruption. And it's rare to have a tender uterus in Praevia, whereas in abruption, you'd often get like a tender and a hard uterus. And with placenta Praevia, you're more likely to get an abnormal lie because, the placenta is sort of in the way. So you're more likely to get a breech presentation. You might get quite a high head on palpation with a placental abruption. And you're more likely to get fetal distress in abruption as opposed to placenta Praevia. Okay, so I've just got a few, just 4 scenarios now, just to test you guys on antepartum and on like bleeding before 24 weeks and after 24 weeks. So let me see if this works. Sorry, give me one. Okay, so next one. Okay, so 25-year-old woman at 25 weeks gestation, she presents with constant lower abdominal pain and a small amount of vaginal bleeding. On examination, her blood pressure is 90/60. Yeah, perfect. So the answer is placental abruption. And the clues to this answer is the pain, the small amount of vaginal bleeding, so it's not in keeping with the amount of pain, the pain is constant. And on examination, she is hemodynamically unstable. So often in your questions, they might ask you what the most likely thing is. So she might have placenta Praevia as well, but the most likely thing in this case is placental abruption. Okay, so the next one, let me just see if I can hide the answers. Okay, so a young woman at 30 weeks gestation presents with painless, bright red vaginal bleeding. She's got 2 previous episodes, but this is a bit more severe. You've got a high presenting part, uterus is non-tender. So what do we think is going on? Oops, sorry. Shouldn't do that. Let me go back. Yeah, so you guys should be able to answer it now. Yeah, exactly. So it's placenta Praevia. Okay, next one. You've got a 19-year-old woman. She presents with a 2-day history of central lower abdominal pain. She's got some vaginal bleeding as well. And her last period was 8 weeks ago. So what do we think is going on here? Perfect. Yeah, this is an ectopic pregnancy. Well, that's the most likely thing that it could be, and something that you have to rule out. Okay, and last question. You're called to see a 25-year-old 10-week pregnant lady. She's got abdominal pain, heavy vaginal bleeding. Her observations are normal, afebrile. On ultrasound scan, they've done an ultrasound scan, and they're able to see a fetal heart rate, and the uterus is the size expected. On examination, os is closed. How would you classify it? Yeah, exactly. So it's a threatened miscarriage. And you can easily sort of say it's not inevitable or incomplete because the os is closed, and it's not a missed miscarriage because she's actually presenting with heavy vaginal bleeding. And it's not a complete miscarriage because in a complete miscarriage, you should have already passed all the products and there'd be very little bleeding with a complete miscarriage. So it's most likely to be a threatened miscarriage. Okay, so next we'll go through, let me just have a look at the time. Okay, so next we'll go through primary postpartum and secondary postpartum hemorrhage. And this is really a useful way of classifying the different causes of primary postpartum hemorrhage. So you've got your 4 T's: tone, tissue, trauma, and thrombin. And tone is the most common cause of postpartum hemorrhage. And that's the one that we sort of usually start treatment for. So how do we define it? So we've got a blood loss of over 500 mils if it's a vaginal delivery, or over 1 liter if it's a C-section. And risk factors for uterine atony is maternal. You can have uterine overdistension, so things like polyhydramnios, having a twin pregnancy, macrosomia, anything that would overdistend the uterus might mean that it's less likely to sort of like contract postpartum, which can then give you postpartum hemorrhage. Labor, so if your labor has been induced, if it's prolonged, all of these might increase the risk for uterine atony. And placental problems as well, so Praevia, abruption, previous PPH, all of these things increase your risk. So when it comes to if tone is the problem, you always start with conservative, medical, and surgical. So conservative is you do bimanual compression, and that's what the picture A basically shows. And you basically massage the uterus to stimulate uterine contraction. You can give drugs as well. So you can give oxytocin, ergometrin, carboprost. All of these are basically drugs that stimulate the uterus to contract, thereby stopping the bleeding. And you can also do surgical measures as well. So picture B basically shows balloon tamponade. So you can leave a balloon in, which basically stops the bleeding, and it basically tamponades the bleeding. And you'd leave it in maybe for like a day or so. And it also allows you to monitor how much blood she's passing as well. And then basically once you're happy with it's a bit like a surgical drain essentially. And you'd basically remove it 24 hours once you're happy with the output. You can also put a hemostatic suture in as well. And worst case, at the very, very end, you might do a hysterectomy if all of these other measures fail. When it comes to trauma, basically, trauma is essentially if you've got any kind of laceration in the vaginal mucosa or in the uterus, you'd basically just repair the laceration, you'd put a suture in. And but if you've got uterine rupture, then you want to convert it into a laparotomy. You basically do a hysterectomy, or you try and repair the site of the rupture. But most commonly, you'd end up with the hysterectomy if it's something as severe as a uterine rupture. And when it comes to tissue, so that's basically where you've got a retained placenta. So you give IV oxytocin to cause the uterus to sort of like contract and try to expel the tissue, or you do manual removal, which is where you sort of put your hand in and you basically try to separate the placenta from the placental bed. And that's manual removal of the placenta. But it's really important to give prophylactic antibiotics in theater because you are going in and trying to remove it. So there's an increased risk of infection. Thrombin is the most rare cause of PPH. And essentially, you consult hematology, you'd correct the coagulation abnormalities with blood products. So yeah, I think the thing to remember is the 4 T's and what are the different drugs that you'd give for PPH, because that's something that's commonly asked. Secondary postpartum hemorrhage is from 24 hours to 6 weeks, and it's basically excessive blood loss during this time period. And the differentials are essentially it's either infection or it's retained products. And if it's an infection, you'd get things like fevers, rigors, lower abdominal pain, foul-smelling lochia. If it's retained products, the uterus might be enlarged. And again, gestational trophoblastic disease again, but it's very rare. And if if someone has secondary PPH, you would do a pelvic ultrasound, but it can be quite difficult to differentiate between what might just be blood clots and what might be retained products. Management is you can give them antibiotics, especially if you think there isn't any suspicion of retained products. It's more likely to be just endometritis, and you can give them antibiotics. But if the bleeding is quite heavy, if it's continuous, if it's not improving with antibiotics, then you might have to do an ERPC. And I've shown you that picture already. So it's evacuation of retained products. And you'd usually send these products off for histology to, again, exclude a molar pregnancy or gestational trophoblastic disease. Okay, let me go back to the to Menti and let you guys answer this one. Oh, I think, yeah. So she's got a major PPH. You think tone is the reason, and you've basically initiated the protocol. You've tried uterine compression. What do you do next? Show results. Oh, there you go. Okay. Yeah. So the thing that you would first give is oxytocin. Then you might give ergometrin as well. And then you'd go for IM carboprost. And then misoprostol as well. And only after those things haven't worked would you then proceed to tamponade. That's usually what most protocols for PPH sort of like ask you to do. So the next thing I thought we would cover, let me actually check so I'll try and answer as many questions as I can. I'm just aware that we've got quite a lot to cover. There's a lot of questions. Okay. Are all women given oxytocin during labor or C-section, or only those with risk factors? So only those with risk factors, or those that you're suspecting, there's going to be quite a lot of bleeding. Often, sometimes during C-section, they might just ask to give, it's sort of like very much dependent on who's doing the section. They might just ask the anesthetist to give they might just ask them to give a dose of oxytocin, or like they might ask them to start like a syntocin on an infusion. So it's very much dependent. But if they've got risk factors for PPH, you definitely keep all of these drugs ready. And that's something that they discuss at the very start when they do like the WHO checklist. They'll keep all of those drugs ready, especially, if it's placenta Praevia, and you'd want to keep those drugs ready. Okay, I think that's all of it. But yeah, if there's anything else, I'm happy to answer it later on, or if you guys can just email me the questions, I'm happy to do that. So the next thing I thought we'd cover is nausea and vomiting in pregnancy. So the important thing to note is it's a spectrum, and morning sickness is actually really, really common. And hyperemesis is not as common, but it's got a devastating impact on the woman, just because, we see women that come in 8-10 times to hospital because it's really difficult to manage. And we try lots of different antiemetics. And they've got a lot of weight loss. We've seen women who've had lost 20% of their body weight, which is insane, which is, quite a lot. And these women get quite weak, especially because they're not able to keep anything down. So just remember that it's a spectrum. And hyperemesis is at the very, very severe end of the spectrum. So pathophysiology, I've mentioned this already, rising levels of beta HCG, and that's released by the placenta. This triggers the chemoreceptor trigger zone, and this is seen in multiple pregnancies and in trophoblastic disease. So anyone that's presenting with very severe vomiting in pregnancy and they haven't had a scan yet that confirms that they've got an intrauterine pregnancy, that it's a singleton pregnancy, it's really important that we get them a scan at some point, either during their admission or once we've discharged them. So it's important for them to get a scan. And check the thyroid function test. I've already mentioned this because beta HCG has TSH-like activity, so it's associated with hyperthyroidism. And this usually occurs in the first trimester, and it subsides by around 14 to 16 weeks. So a question for you guys, what is the classical triad for hyperemesis? Ketonuria, yeah. Weight loss, yes. I don't remember what the last one is actually. Dehydration is, yeah, so dehydration, weight loss, and electrolyte disturbance. Good. Exactly. And the ketonuria is something that's really important because it basically decides whether you'd admit someone or whether you'd observe them for a period of time. So the ketonuria comes into that. So yeah, this is your classical triad for hyperemesis. And these are just things to keep in mind and things to basically treat when it comes to the management of this condition. And risk factors, if it's your first pregnancy, you're at increased risk. If you've had it before, if you've got a raised BMI, and we've already mentioned multiple pregnancy and gestational trophoblastic disease. So when it comes to the management, the first line options are mainly antihistamines, and you've got cyclizine as well. The second line options are either you've got your dopamine antagonist, so metoclopramide, you've also got ondansetron as well. And very, very severe hyperemesis, if none of these are working, then you might consider starting steroids. And when to consider admission. So if they're unable to keep fluids down, failure of oral antiemetics, ketonuria, weight loss, if they've got any comorbidities, things like diabetes, UTI, then you might consider admission. Or at least if you're in the GP setting, you'd ask them to go to A&E. And other management options. So apart from antiemetics, it's really important to give them IV fluids. If they've been vomiting a lot, you want to give them PPI for gastric protection. And these women are actually at an increased risk of getting clots. So you want to give them thromboprophylaxis. And do you know why we give them thiamine and folic acid? Because you also give it to alcoholics as well, who might be withdrawing, but why in this case? Yeah, it's actually, it's the exact same reason. So it's, I don't know why it's gone all the way to the top. So it's actually to prevent Wernicke's encephalopathy. So it's the same reason why we would give it. It's sort of like a malnutrition state. So to stop that, you would give them this replacement. Good. So this is the next question. Let me go back to Menti. Hopefully I can hide the results now. Yeah. So 19-year-old, she presents to the GP surgery 14 weeks in. what would we do? What's the most appropriate next step? Oh, oh gosh, sorry. Let me. Sorry, my phone's just, let me go back. Okay, nausea and vomiting in pregnancy. Yeah, so you'd arrange admission to hospital. And the reasons why you do that is, she was started on oral cyclizine, that didn't help. She's unable to tolerate any oral intake, and her urine dip is positive for ketones. So all of these things means that she likely needs IV fluids. She probably needs to be started on IV antiemetics as well. And she might need something else. She might need to get started on something else while she's in hospital, just so you can optimize her management when she leaves the hospital. And why you wouldn't repeat an ultrasound scan is because she's already had a normal dating scan. So there's sort of very less, that you're going to get from repeating an ultrasound scan. Advising bed rest, probably not the case. Switch antiemetic to metoclopramide. You'd only start that if cyclizine is not working. And you probably do that, when she gets admitted to hospital. And reassure, as most women experience a settling. So that's again not appropriate because she's positive for ketones. She needs something more. Okay. So itching in pregnancy, I thought we'd go through some of the dermatological presentations when it comes to itching in pregnancy and then go through the other stuff. So there's three main derm conditions that gives you itching. And it's sort of like I try to remember it as a spectrum. So atopic eruption of pregnancy is the very, very mild end of it. So it's sort of like an eczema type rash. It's itchy, it's red, and you treat it like you would any kind of sort of like the mild version of eczema. So moisturizers, steroid ointments, your classic derm stuff. And it just looks like an eczema rash, really. Then you've got polymorphic eruption of pregnancy. That's where you'd see classically in the third trimester, and the lesions first appear in the abdominal striae. And again, you'd start emollients and topical steroids first, and then oral steroids. And that's sort of like what it looks like. So it usually starts in the abdominal striae. And the last one, so this is the one that sort of like sounds a bit more scary as well. So pemphigoid gestationitis, you've got blistering lesions, and it starts periumbilical, but it sort of like spreads everywhere. And this is what needs, it looks a lot, it's blistering. So you're going to try for oral steroids before you try topical. So you sort of like give them a course of oral steroids, and hopefully that should resolve. I think those are the three main derm things that you need to think of, they need to remember when it comes to itching in pregnancy. But the other really important thing that you need to exclude is obstetric cholestasis, because that also gives you itching. But there's some classic things to do with, that you'd see with the itch in obstetric cholestasis. And again, that's third trimester. And it's usually in the palms and the soles, and it's worse at night. And it can be quite severe. And you might see lots of signs of excoriations as well. Other features, you might get jaundice, malaise, anorexia. It can give you a cholestatic picture, so the dark urine and pale stools, and steatorrhea as well. And the risks of OC is sudden stillbirth, which is why it's really important that we pick it up and we monitor these women. It's also a risk factor for PPH and meconium passage. So investigation. So the main thing you do, it's cholestatic. So you do LFTs, do bile acids as well, because that's really important. And you'd basically repeat this every 1 to 2 weeks after diagnosis. And you give them ursodeoxycholic acid for two reasons. First, it gives you symptomatic relief. And second, it may also help you reduce bile acid levels as well. And because these women are at increased risk of bleeding, and because there's like a certain element of liver dysfunction as well, you basically you give them vitamin K supplementation. And that helps the newborn as well. And you basically induce them at around 38 weeks. I've sort of read different things, but if the bile acids are very high, you basically want to induce them and you want to expedite delivery. That's the main thing. Yeah, so don't ignore the itch. So with itching in pregnancy, this is something that you want to rule out. Okay, let me go to the next one. So I think okay, yeah. So with this, like I said, you've got itching in pregnancy. The reasons why you think this is likely to be OC from the history alone is the fact that the itching is specifically on her hands and feet. And she's not noticed any other rashes as well. So it's purely just the pruritus. And she's got a family history, I think. Yeah. That's another thing. She's otherwise well. So before you do any of the derm stuff, the thing that you want to check is the LFTs and the bile acids. Okay, let me just see if there's any questions. Is prurigo of pregnancy the same as atopic rash in pregnancy? I don't know what prurigo of pregnancy is. It might be the same thing, but I'd look it up. Yeah, because I'm not sure. I haven't actually read that. Haven't heard that before. Okay, so the next thing, the last bit actually, I thought we'd go through routine antenatal care. So we'll start off with scans. Do we know when we scan women in pregnancy? So the routine scans that we do. There's only 2. So do we know when we do these scans? So you've got your 12-week scan and your 20-week scan. Good. And there's like a variation, basically. You've got like a range, but essentially you've got your dating scan and your anomaly scan. So I've got 8 to 10 weeks. That's sort of like when you want your booking visit to happen, but it can happen until 12 weeks. That's fine. And then basically during the booking visit, you want to date the pregnancy, and they look at different measurements of the fetus to basically do that. And you also look at the nuchal translucency as well. And do you guys know why the nuchal translucency is important? Downs, exactly. So that's basically used as part of your chromosomal abnormality screening for the combined test. Good. And the second one you guys have mentioned already, you do it around 20 weeks, but anywhere between 18 to 21. And that's your detailed ultrasound scan looking for structural abnormalities. Good. So those are the 2 main scans that we do. So when it comes to blood tests, at your booking visit, you basically do things like FBC. You do serum antibodies as well to look to see if the woman already has any antibodies. Then you screen for syphilis, HIV, and hepatitis B, and also for sickle cell and thalassemia. They used to screen for rubella in the past, but they don't do that anymore. So that's something that's not part of your routine antenatal care bloods. And then at 28 weeks, you sort of repeat the bloods again. So mainly you'd repeat your FBC and your antibody screening. And then you also do your OGTT, which is your oral glucose tolerance test. And we'll go through that sort of like later on when we cover maternal conditions in pregnancy. But if you've got any risk factors, you'd basically do it between 24 to 28 weeks. That's when you do that test. But if you've had GDM in a previous pregnancy, you might do it earlier. And if someone is rhesus negative, then basically you'd give the anti-D at 2 points. You'd give it at 28 weeks. And you'd give it at 34 weeks as well. This is your routine prophylaxis. But obviously, if they've had any other desensitizing events, then you'd give it, in addition to these 2, you'd give it then as well. And when it comes to screening for chromosomal abnormalities, so do you guys know what the 2 types of screening tests that you can do are? Combined, yes. Combined and quadruple, exactly. So with the combined, as the word suggests, so it's a combination of scan results and blood test results. And the way I remember it, I try to remember is A and B is combined, and then for the quadruple, it's A, B, C, D. It's just like one of the weird ways that I try to remember it. But I think this is sort of like one of those things that's very short-term memory. You just got to remember it before your exam. Because it's just one of those things that they might ask you in an MCQ test. But quadruple test is 4 blood tests, whereas a combined test is your scan and 2 blood test results. And beta HCG is used in both the combined test and the quadruple test. And the quadruple test, actually, the thing to remember with that is it's less accurate and it only screens for Downs, which is not something I knew, actually. The quadruple only does Downs, whereas the combined does 21, 18, and 13. So Patau and Edwards as well. So the important thing is quadruple has these 4 ones, and AFP, inhibin, beta HCG, estradiol. If you try and remember is A, B, C, D, I think that's one way. But if you guys have your own way of remembering it, that's absolutely fine. So that's basically your routine antenatal care, all the chromosomal abnormality screening, your blood tests and your scans. And I think that's the main things that you guys need to know when it comes to the screening that we do. This is a really good sort of picture, actually. I think I got that from NHS screening. And it basically tells you all the different screening that we do. The good thing is it's got the newborn screening as well. So it's got all the different things that are on the blood spot screens. It tells you when they do the hearing screen, the infant physical examination. So I think this is really good because it shows you everything from like preconception to the newborn screening. So yeah, it's something for you guys to look at when you guys get the slides. And okay, so I might just skip Menti and just let you guys answer on the chat. So you've got a nervous 42-year-old. She's worried that she has missed the right time to have a combined test. So you're going to give her the quadruple test instead because she's now 17 weeks into her pregnancy. What assays make up the quadruple test? So the I'll come to that after. Yeah, so it's D. Someone said B. So let me just see what the difference is. It's the same thing. Oh, it just says HCG unconjugated. So it's D because you've got the AFP, inhibin B, beta HCG, and estradiol. So the only thing that's different is that this says, oh, it's inhibin A in option B. So it's inhibin B that you look for with the quadruple test. So it's like a minor thing. But those are the 4 tests. This is just something that I thought to like test you guys, being able to remember the 4 blood tests. But yeah, I think that was another question actually about whether you would take consent. So yeah, you definitely take consent before you do the combined test. And, you know, women are like absolutely in there, you know, they have the right to opt out of it. So it's something that you can opt out of when it comes to the chromosomal abnormality screening. So you just counsel them and you give them all the information and, you know, they're in their right to opt out of the screening program if they want to. Let me see if there's any other questions. Oh, what serum antibodies do you test for? So I think it's, I can't remember all of them, but it's all of the blood ones, you know, all of the antibodies that you can form against the different blood groups. Those are the ones that you test for. I can't remember the names off the top of my head. There's definitely certain serum antibodies, probably something to look up, actually. I think that's all the questions. Okay, so we're actually coming on to the very last thing that I wanted to cover, which is rhesus incompatibilities. This is something that you might get asked to explain. It's a good OSCE station, I think, because it's something that it's a very complex concept that you might have to explain to someone. So basically the easiest way to explain it is, you know, when you tell the woman, you want to tell her that, you know, every blood group is made up of a letter and then a plus or a negative. So, you know, you can be O positive, A negative, and the negative is basically your rhesus status, whether you're positive and negative. So the main problem with rhesus incompatibility is if the woman is rhesus negative. So for example, if I'm O negative and my baby had a positive blood group, so my baby was O positive, for example, that's when the problem arises. And what happens is during pregnancy and during any of these sensitizing events, so for example, if you've got any bleeding, if you've got like a miscarriage, ectopic, any of these events, then that basically causes mixing of the mom and the baby's blood. And once the baby's blood enters the mom's circulation, because the mom's blood basically produces antibodies against the baby's blood, and it's not a problem in this pregnancy, it's a problem in the next pregnancy. So what happens in the next pregnancy is these antibodies can then pass onto the, you know, it can cross the bloodstream, and it basically causes the blood cells to break down. And what it does is it causes, you know, it causes increase in bilirubin, you get the jaundice, and you can get kernicterus, which is the brain damage that you can get as a result of the increased bilirubin levels. And so it's basically a problem with future pregnancies. And the reason why we give anti-D is it basically mops up all of the fetus's blood cells that cross into the mom's circulation, and it stops the mom from producing the antibodies. And it basically protects. So it's more of like a preventative measure to stop her from, you know, from these antibodies destroying the cells of the future, any future pregnancies. Yeah, I hope that sort of like made sense with rhesus incompatibility. But we obviously never check the blood group of the baby. So any mom who is rhesus negative, even if the baby is positive or negative, she would get the anti-D injections. And you'd give it at 28 weeks and at 34 weeks. That's your prophylactic, and any additional ones you'd give for the sensitizing events. Okay, so at a booking visit, a first-time mom is told that she's rhesus negative. Which of these answers is the most appropriate advice for the mother? So again, we'll just use the chat for this as well. Yeah, so it's C. So it's not actually about the baby developing antibodies, because the baby is not going to develop the antibodies. It's the mom who's going to develop the antibodies. And if you do have bleeding before 12 weeks, then you don't really, it's mainly bleeding after 12 weeks. I don't know why they've got that cut off, but that's usually what we advise women is after 12 weeks, if you've got any bleeding, then be sure to get an injection of anti-D. And it's not D because it doesn't matter if your partner's rhesus negative. It's more to do with the mom's blood group, because it's the mom's blood that's going to, come into contact with the baby's blood cells. You need one injection to cover your pregnancy, even if you have episodes of vaginal bleeding. So if you've got episodes of vaginal bleeding, then you'd give them the additional anti-D. So the answer is C. So anti-D will stop your body from creating antibodies to your baby's blood, which help protect the health of your next child. So it's more of like a prophylactic thing. So yeah, so the two dates are 28 and 34, yeah. Okay, so just lastly, I thought I'd just go through some useful resources. So PassMed was amazing. That's what I use to test myself for Obs and Gynae content. The BMJ has some really good visual summaries, especially for things like diabetes in pregnancy, hypertension in pregnancy. And like I showed you, like all the different management options for hyperemesis as well. So they've got really nice diagrams. Osmosis is great, especially for the rhesus hemolytic disease. If my explanation did not make very much sense, I definitely recommend watching the osmosis video. They're really good for lots of different concepts, especially things like preeclampsia, like the pathophysiology stuff is covered really well in osmosis. If you guys haven't come across it already, you probably have. And NICE guidelines is really good just for like the management and the investigation. I think mainly with, I mean, I can only speak for King's, but in King's for the, for the early clinical years, they'd usually ask you things like, what is the diagnosis? Whereas when it came to the later clinical years, so like fourth year, final year, they'd ask you things like, what's the first investigation you would do? What is the most diagnostic investigation? What would your initial management be? So it's more sort of like management focused. So NICE guidelines are quite good for like the diagnostic management stuff. And this is the textbook that I use. I know a lot of people use the clinical specialties textbook, which is really great, but I just liked the way that they explained things in the Lawrence and Impey, the Lawrence Impey textbook. So yeah, this is the one that I used, which I think covers all of obstetrics and all of gynae like quite well, actually. And it's got lots of like really nice diagrams and stuff as well, which I found quite good. Oh, okay, let's just thank you. I thought that was like a lot of questions. I was like, who's 18 questions? But yeah, that is everything.